Welcome back. We're discussing tuberculosis with Dr. Angela Emechebe. Now you can join us, ask your questions by phone. Questions concerning the topic, of course. The number to call is 0808-054-2233. That's 0808-054-2233. And you can tweet at CTV_Mary A. And we continue to talk about prevention. So now that you have mentioned, or at least most of the preventive strategies
that we doctors,
yes,
not for the patient.
I want to ask about the patients now.
Okay, so
not just the patients,
generally,
people, yes.
So we would say let me start with the patients that have TB already and they have family at home. Please bring in your family for what we call contact tracing, where we do a free GeneSPAT test. We check your sputum, it's free. Then we ask you to go and do a chest x-ray. So just in case the family members have TB, everybody can be treated at the same time. And the drugs are also free. Nobody charges you for anything.
Assuming you don't get to find TB in any of them, how often do they have to come for checkups like that?
Their family members?
Family members, yes.
No, family members, we just see them the first time.
Okay.
Do all their tests and then discharge them from the clinic. But if they come down with the symptoms again, or if they come down with any symptoms, then we run our tests.
Okay.
But for the patient that is already on the drugs, we also do 2 monthly tests, 3 months. So not that we're just giving you anticox without checking if you're sputum negative or if you're sputum positive. Then for others for the general public, I would say we need clean environments, because microbacterium loves very dirty environments. It breeds there. It loves overcrowded areas. Proper nutrition as well. Let's educate ourselves. Google is there. Read it. Go online. If you have a friend in church.
Let's take this call. Sorry to cut you short. From Paul. Hello, Paul.
Okay.
Hello, Mary. Good afternoon.
Nice to hear from you. What's your question?
More like a contribution, actually. I think the education aspect of it is really encouraging for people in the figures. But the biggest challenge with the DOT treatment is, aside Lagos and the West generally, getting the DOT looks like a burden. Because most times when I try to observe what happens around, what you see is they practically beg for the DOT, even though we know they are free. So occasionally, I live around the teaching hospital. I try to see with some of my colleagues that work in the hospital, and I see what patients go through. They practically beg for a 6-month therapy. For somebody that has done 3 months, 4 months, why would the person not want to complete it? But I think we need to look at that perspective. Getting the drugs, I don't think should be a big burden. It should be made easy. You get there, you get it, and you're out.
Okay, thank you very much, Paul.
And another thing, in cases where you need to move to other places, continuing the therapy now becomes a problem. If there's a way we can address that, it's fine.
I didn't quite hear the second thing, but did you hear
He was talking about when people need to relocate.
Okay.
So what we do, say we're seeing someone in the chest clinic in Lasut. If the person is moving out of town, we give a referral letter.
So that he can have the DOTS program in the area
wherever he goes to.
But that means there always has to be communication between him and his doctor.
Yes.
But then he's talking about difficulty getting the medication.
Mr. Paul, I would even love for you to personally come to chest clinic and ask for Dr. Emechebe. Not because I work there. The patient's time is very short. We try to be as fast as possible when we're seeing our patients. Why? You don't want to keep them. It's a contagious disease, so you don't want to keep the patient for long. And the drugs are free. Nobody would say, don't get the drugs. You'll be so amazed that a lot of people don't even know about this DOTS program.
Yeah.
Now we're incorporating HIV too. So we see HIV patients that have TB in our clinic.
Okay. HIV and TB. That's another thing.
Yes.
TB just seems to love HIV positive people. So do we call it an opportunistic infection?
Because one of the risk factors, or rather one of the the group of people that mostly get TB are people that have immunosuppression.
So how
and
easy
immunosuppression
is it for
is
you
HIV.
to handle HIV patients?
It's easy. We work together with hematology department, so they give the drugs, we manage the TB, and then when we're done with our own management, run all our tests, make sure the patient is okay, we refer back to them.
Up until 2015,
yes,
we're talking about 480,000 cases of multi-drug resistant TB. First of all, how did multi-drug resistant TB come up?
Okay, multi-drug resistant TB is just that Mycobacterium tuberculosis has some of its strains are
okay,
resistant.
Let me hold you there.
Okay.
Multi-drug resistant TB, but let's take a call.
Okay.
Hello.
Hello.
Is that Paul again?
Yeah, no, Paul from Abuja this time.
Oh, Paul from Abuja this time. Welcome,
Paul.
Paul. We're having a lot of Pauls. What's your question?
Yes, the question I have is, I was told that if you have HIV, you have a symptom of tuberculosis too. I want to have idea about the different symptoms in tuberculosis in ordinary TB and that of HIV.
Okay.
Same thing.
That's a good one. Thank you, Paul.
Okay.
Is there a difference between the symptoms of TB?
They are totally different, yes.
Totally different. So what does it look like in somebody with
somebody with HIV would tell you that they have unexplained weight loss for 3 months. They are coughing, but in most cases not blood, and then they have diarrhea.
Okay.
While in tuberculosis, it's mainly cough, night sweats, chest pain. You don't have night sweats with HIV.
Okay.
So they are totally two different, even though some of the symptoms mimic each other. So most times what we do for all patients that come in for the first time that are coughing, we also do HIV test. It's compulsory.
Okay,
all the patients that come into our clinic, you must do your HIV test, so that if you have HIV, we treat the two together.
And in conjunction with the
HIV drugs,
specialist as well.
Yes.
Okay, we were talking about the multi-drug resistant.
So this multi-drug resistant, how did it come about? Poor adherence. Some of the strains of Mycobacterium, they are resistant to rifampicin. So we warn our patients, please don't default. These are very strong antibiotics. And you can imagine you've taken this drug for 4 months and you stop
taking it. Let's take another call. Okay. Hello, Henry.
Hello, Madam Doc.
You're welcome.
Afternoon.
Good afternoon. What's your question?
Please, there is this man I went to visit last week. Though he's suffering from this tuberculosis and diabetes, and I don't think he's financially buoyant enough to take proper care of the situation. When I got to his place last week, I found one of the leg swollen and smelling very bad. And I asked if he has gone to hospital. He said he invited somebody that is treating him at home, and he has families, little children. So I don't know. I don't really know how to.
Henry, is he in Lagos or is he in Abuja?
He's in Lagos, Surulere.
Okay. Thank you, Henry, for that.
Okay.
Diabetes and tuberculosis.
Okay. So diabetes, it's on its own. There's no relationship. If you have diabetes, take your drugs, treat the TB, and you'll be fine. The swollen leg could be as a result of diabetes.
And I don't think somebody should come and be treating him at home, should they?
No. So that's where our multi-drug resistance comes in.
Okay. But we can't take any more. It's time to go. Thank you so much, Dr. Emechebe, for coming. That was a wonderful time we had with you. And that was a great time we had with you at home as well. Paul and Henry, thanks for calling. Have a wonderful day, everybody. I am Mary Alale Yusuf.